Srihari, and this is the University of Chicago Public Policy Podcast.
Hey UC3P listeners, I'm Steve Crano, a second-year MPP candidate at UChicago Harris. Thanks for tuning in to Chicagoland. Today's episode features Dr. Allison Arwady, Commissioner of the Chicago Department of Public Health. Trained as an epidemiologist, Dr. Arwady served as an Epidemic Intelligence Service Officer at the Centers for Disease Control and Prevention, as well as Chicago's Chief Medical Officer before her current role. Dr. Allison Arwady, thank you so much for joining us on Chicagoland today. So can you talk a little bit about how the commissioner's position is different from that of a chief medical officer in a public health department?
So first of all, I'm a physician by training. I have training in internal medicine and pediatrics. And so in my role as the chief medical officer, that has a particularly medical focus to it. So I was overseeing what we call our Health Protection Bureau. So that includes all of our disease control activities. So when you think about public health, that includes things like immunizations and our tuberculosis response and outbreak response. It also includes our environmental activities. So that's everything from restaurant inspections and food protection to our lead poisoning prevention, home inspections, to vector control, which means mosquito control. And then finally, our emergency preparedness work, which is about thinking if there are large scale events that hit the city of Chicago, what do we need to be prepared for from a health system and city perspective? So I was overseeing all of that from a medical perspective, as well as doing additional work, especially in the behavioral health space. So I did a lot related to our opioid response, for example. Our mental health work falls in that space, our violence prevention work. So I know those areas well and work very closely with a lot of the other medical directors, for example, here at the department, as well as the teams. So in the new role, I continue to have, obviously, sort of ultimate responsibility for those programs in that area, but my scope of what I now need to have more responsibility for obviously broadens to really across the whole department. And so there are some content areas that I already have a fair bit of knowledge and expertise in, things like our HIV and sexually transmitted infection work, things like our maternal and child health, our adolescent health, which I've been involved with, but haven't had that same direct oversight. And then obviously with the commissioner role, I need to pay a lot more attention to things like our political processes and making sure that the department is really being well positioned, that we're doing a good job of communicating with aldermen and with the public, really making sure that we like to say, raising our public health voice, doing a good job of making sure people have an understanding of what public health is and what the department's role is. And then more related also, I would say, to fiscal and other administrative requirements. So
is there anything that you felt like you wanted to achieve as chief medical officer that maybe you weren't able to focus on because of the scope of that role that now you feel like you can maybe accomplish in this new role as commissioner?
Yeah, it's an interesting question because, of course, the scope only gets wider, as you move into that commissioner role. I think, there's so many things that we do here at the Chicago Department of Public Health. And in every one of those areas, the teams have great ideas. They want to, increase the number of traps we're setting out for mosquitoes and think about predictive modeling for how we're doing lead inspections. And they want to do new innovative things for infection control in hospitals, or they want to develop new policies. And I think for me, as opposed to there being one area where I felt like there hasn't been as much capability for me to move something forward personally, the hope is that in this position, I'll be able to guide some of the teams to develop more some of the areas that I have interest in. And so the thing for me is remembering to step back, right? I'm not going to have as much time to be as directly involved in projects, but I think there are particular things related to data and sharing and this raising our public health voice and really helping to set some of that vision for the department in close collaboration with the really, really strong team here that I'm excited about.
So we'd like to take a little step back and ask about your development as a professional. You mentioned some of your early career experiences being outside of medicine entirely. What initially drew you to the field? And specifically, what drew you to epidemiology once you knew you wanted to engage in medicine? Or was it kind of a chicken and then the egg?
Yeah, so it's an interesting question. I do not think I knew the term public health. I certainly didn't know it in high school. Even in college, it was not necessarily something that had come to my attention very strongly. I remember one of my roommates taking a class, this is in the early 90s, taking a class, on HIV, for example, and thinking that was interesting, but it wasn't something that I knew about. And then I was a history and literature major in college, actually. But I really liked science, and I took a lot of biology and science classes for fun. I thought I might want to be a science writer potentially, and I had a lot of different jobs and kind of careers along the way, if you will. But for me, what happened was, to be honest, I was working in New York City, and I was working as a medical and science editor. So I thought this would be great. I really liked the travel guide writing and editing that I had done, but that is not a long-term career. That was sort of summer jobs and then part-time in school and just for a year afterwards. And so this was a full-time job in New York doing medical editing, and it turned out to be a terrible fit for me. It required, sitting very still in a cubicle all day, not having a lot of interaction with people. And I could see that the path was going to be very long to get to the piece that I wanted to do. And it was just not a good fit. And I thought about medical school in a, it's not like it had not crossed my mind, but I had not been pre-med undergrad. And the good thing was I disliked that first job so much that it pushed me to really reassess what I wanted to do. And so I'm living in New York City. I was not willing to go into a lot of debt for, potentially taking all these other courses I would need. And so I got a job working full-time in a medical setting to assess, was this actually a field that I liked? And then plus, if I could find a job that would pay my tuition in the meantime, I wouldn't go into all this debt. And so, luckily I got a job at what was then called Columbia Presbyterian Medical Center in New York City, and I was a technician. I hooked people up to EKGs and had them run on treadmills and helped be part of this cardiovascular exercise lab. And number one, it made me realize I really liked this setting. I liked the physicians I was working with. I liked the patient piece. I liked the research piece. But also, because I was a full-time employee, it covered my tuition to be able to take the night physics and chemistry classes. And then, by chance almost, I took this intro to epidemiology class because you could take classes for free with the tuition. So I would take like one chemistry class and then a graduate student class in American history, or architecture or other things just because I was interested in them. And so I took this epidemiology class, and really I took it and I was like, what is this field? Like, it just was this instant thing for me where I said, this is what I love. Like this science, but mixed with sort of thinking about patterns of disease, thinking about really big picture issues, and how can you use science to answer them.
Given that you spent some time abroad and are interested in, international public health issues, I guess ultimately what led you to focusing on public health at a more local level in Chicago, and did that experience abroad does it continue to inform the work you're doing here today?
The public health approaches that are needed are key. Like we talk a lot about root causes of health, right? And that the medical piece is a very small part in terms of health, and that health and public health can be a really strong platform to kind of advocate for larger changes in a society. And so when I was in the Epidemic Intelligence Service, I had the opportunity to do, that's mostly about outbreak response, by the way. And so I was able to, with CDC, to be part of a team that, was in Saudi Arabia working on the Middle East respiratory syndrome outbreak. If you remember that from a few years ago, this novel respiratory virus, really interesting. And, that was one of the most unique experiences I'd ever had. And then that was followed by being able to be part of the CDC team in Liberia, responding to the large Ebola outbreak. And that, especially the first time, I went with the team right near the beginning, before it had been declared a public health emergency of international concern, and really seeing what a major outbreak can do to a society, and working to support the Liberian Ministry of Health in trying to organize a response to that in a setting where there just weren't enough resources was hugely, disturbing, I would say, and very motivational in terms of saying, this is not, in many of these cases, it's not about people who are not dedicated. It's not about people who don't know what they need. It's literally, it can be this lack of resources. And so watching, back in the U.S., finally, when eventually more resources did come, and I was able to go back to Liberia about 6 months later and see that now there actually were, secure places to be able to treat people who were infected. And there were many teams of people who could follow up on contacts, and very well organized systems by and large. And that's all, that's resources, that's organization, that's the basics of what kind of public health can do in a response, working with the medical system. And so, in our day-to-day work here in Chicago, there's something different about being able to do this kind of work in the city that is your own city, taking these same lessons about getting organized, about, making sure that resources are appropriate in the medical system, building strong public health capacity outside the medical system, thinking about communication, and being able to do that work in the place that you yourself live. I've loved doing that. Having had a lot of exposure to international settings along the way, you notice things differently when you're in a setting that's not your own, right? And so once you're used to noticing things differently, I think it makes you think differently about how the system you've always been in actually could be different, for better or for worse.
That definitely resonates with me as someone who has been interested in issues abroad and having studied abroad as well, but have a very strong interest in local policy. And I think there's often kind of a disconnect between the two, not really understanding how a perspective from abroad can really inform the way we think about our own systems.
Working and living in environments that are not the ones that you were born into is a very good way, I think, to build that humility. I
think that applies for everything, public health included.
Yeah.
So to continue down this path of kind of focusing more on Chicago, can you talk about one of the perhaps greatest challenges that you've faced regarding a public health concern in the city, and what the department has done or is doing to mitigate that public health risk?
Sure. I think I'll talk about the opioid crisis probably. It's one of the areas that I've focused a fair bit in, especially in the last couple of years. And, you may or may not know, but we have almost 800 people a year dying in the city of Chicago from opioid overdoses.
Did not know that number.
Yeah. That significantly outpaces the number of people in Chicago dying of gun violence, for example, dying from car accidents. It has really emerged as a major source of mortality. And in addition to the people dying of opioid overdoses, we see many non-fatal opioid overdoses across the city. The Chicago Fire Department is responding to an average of more than 20 a day across the city. We have opioid overdoses in every community area, and we have fatal opioid overdoses in almost every community area every single year. And this increased really dramatically in the last few years, largely because we saw something called fentanyl come into our drug system. So not our drug system, but into our illicit drug supply. So most of the, if you kind of listen to the national narrative about opioids, it's a lot about prescription drugs. It's a lot about young white men in especially rural areas. And there is a huge problem with prescription drugs in young white men in rural areas, no doubt. But in the city of Chicago, that is not what our opioid epidemic looks like. It is not driven by prescription drugs. In fact, here, although there's always room to continue to work on prescribing practices, Chicago physicians prescribe opioids at rates below below Illinois rates, and then Illinois is below the rest of the country. And when we actually interview people about are they misusing prescription drugs, our rates are very low there, not the main concern. It's being driven by heroin and then fentanyl, which is this extra strong version of an opioid that has gotten into the supply. And so it's not prescriptions, it's illicits. We talk about young, white, rural men. Obviously,